Hello and welcome to the Days of Learning podcast. I'm your host, David Nelson, and we are thrilled to bring another episode where we talk about health and wellness and how we can make better connections to community. I've been excited to have this guest on since he agreed to come on. I want to welcome Nathan Lamberton. Dr. Lamberton, welcome.
Thank you. Good afternoon.
And Dr. Lamberton is a pharmacist. He is a doctor of pharmacy, and he's a board certified pharmacotherapy specialist. And he joined the Medical College of Wisconsin School of Pharmacy as an assistant professor and is also at the Ascension Columbia St. Mary's Family Medicine Residency as a primary care clinical pharmacist, and the Saturday Clinic for the Uninsured as the pharmacy director in the summer of 2017. He received his Doctor of Pharmacy degree from the Albany College of Pharmacy and Health Sciences in 2015. Prior to joining MCW and Ascension, Dr. Lamberton completed a 2-year ambulatory care with a family medicine focus pharmacy residency and a longitudinal 2-year faculty development fellowship with UPMC St. Margaret in Pittsburgh, Pennsylvania. That's the University of Pittsburgh Medical Center. Dr. Lamberton's clinical practice focuses on providing direct patient care, specifically chronic disease management, while working within the complex medical and psychosocial needs of each individual patient. And our show today is sponsored by the Center for Disease Control and Prevention 1815 grant. So Dr. Lamberton and this idea of chronic disease management, it is a perfect fit for us. Dr. Lamberton, welcome to Days of Learning podcast. So good to have you on.
Terrific. Thank you for having me. I'm so happy to be here and to share what I can with the community and also, talk about the learning that's really happened in my life from the community as well. So thank you so much.
We're going to get into this idea of what is a pharmacotherapy specialist. It was even hard for me to say. I had to spell it out. But I want you to tell our listeners a little bit about who you are, because I find you an interesting individual, and I just want people to know a little bit more about you. Tell us about your journey.
Absolutely. I'll keep it as brief as possible, but my story starts in a very small rural town in upstate New York. Much of my life was spent growing up in very small farming communities, very similar to what you find in most of Wisconsin as well. And my passion for healthcare really came by way of family members who practiced in healthcare themselves. So I had a mother who worked for a pharmaceutical company. I had an aunt who was a 40-year veteran nurse. And I had multiple cousins who were also pharmacists. So I always knew from a very early age that healthcare was something that I wanted to do. And admittedly, when I was very young, even into my teenage years, I was quite shy and very reserved. And I never really would have thought that I would pursue a profession that requires so much communication with patients and other providers. So from a very early standpoint, I knew healthcare was for me. I just enjoyed helping people, but I didn't really know what that meant. I knew I enjoyed helping people feel better and really just help them in their daily lives. But at a young age, I didn't really know what that meant. So it really came down to what was most important to me. And as I got into my later high school years, I started to realize that communicating with people was something that I was very passionate about. And I always liked the puzzles of how do I best help somebody. So we see people struggling in many different ways. Even from an early age, there were people who had struggles that I innately just wanted to help with. And it was always interesting to figure out how we can best do that. So in my experiences shadowing different pharmacists, I found that path to be one of the more rewarding pathways. I mean, if we can be a part of a profession that takes away suffering from patients through medication use, or at least that's how I understood it at the time, that was the most appealing to me. So from there, I went straight from high school into the Albany College of Pharmacy and Health Sciences program, which is essentially a 2-year undergraduate equivalent preceding a 4-year graduate level program. And that's really where I found my passion for pharmacy. I often joke with people and say that there wasn't really this aha moment that I had before I joined pharmacy, but I could not imagine having done any other profession because of the experiences I got as a pharmacy student.
So you had to dive right in. There was no, hey, maybe I'll take a couple years to take a couple courses and I'll figure out what I want to do sometime. You took 2 years and then you jumped into a 4-year program. So you were serious from the beginning. I want to back up a little bit, Nate. You know, I'm always intrigued about family stories. And yours is interesting in that your mother worked for a pharmacy company and you had family members who were pharmacists. How did that influence you? Specifically, talk about your mom.
So really, I have to attribute the idea of even considering pharmacy to her. I was one of those early adopters to what my career wanted to be when I was much younger. And it's actually kind of funny that you asked that question. In ninth grade of high school, we had a career fair at the school, and the local news company came and was asking people about their career aspirations and what they thought they'd want to do. And young, naive me, who enjoys playing hockey and was always an avid hockey player, said that I was checking out careers in case the NHL didn't work out. So really the idea of pharmacy came from my mother, who worked from a pharmaceutical company, and just, I think she knew me better than I knew myself at that point, knew what I enjoyed and what I'd be looking for. And from her understanding of what pharmacy entailed, from her perspective of a pharmaceutical company, she thought it was a really good fit. So she was the one who really pushed me and encouraged me to reach out to some of the local pharmacists and try to set up opportunities to shadow them and to be around them, just to get a better sense of what it's like. And in our small community that I grew up with, it always felt like home. Even though I was a young teenager in high school, trying to figure out what pharmacy was, I stepped through the door of a pharmacy and I just felt like it was the right place for me. Whether that was by way of the pharmacists that I was working with, who were incredibly knowledgeable and incredibly comforting and supportive, or if it was just that small town atmosphere of community and how individuals look out and help for one another.
Let's talk about that. Let's talk about this idea of feeling at home as a part of the community there. Talk about that from that perspective of pharmacy, what you learned early on from those local pharmacists.
Yeah, that's a really good question, especially as it relates to where I grew up, because the pharmacist and the pharmacy were the cornerstones of the community. Really, from where I grew up, there were pharmacies within 5 or 10 miles of most places. But then you get out to the more rural communities, and the pharmacy is really the only healthcare entity that exists for miles. And the accessibility of pharmacists in those kinds of communities is paramount. A lot of patients will go to the pharmacy to ask the pharmacist questions about their chronic conditions. If they're having some sort of short-term concern or acute illness, they will go and inquire with the pharmacist, what should they do? Is it worth driving that 90 miles to get to a hospital? Or can they use something over the counter or at the pharmacist's recommendation to prevent them from having to make such a long trip? So really from my community's perspective, the pharmacist is really one of the most accessible healthcare professionals and is so highly relied on for information and for knowledge about what to do when things are uncertain.
So the NHL, did they come calling?
They never came calling. I blame it on the fact that I probably left the phone off the hook a couple times, and I probably just missed the call, but no, they never called.
Tell me how being in athletics fit in with studying pharmacy.
Yeah, it's all about the team. And all the sports I played growing up, it was such a team-based environment, and it was always, about more than just one individual person. And getting that experience playing team sports from a very young age, it was always well ingrained into me that you can contribute, but you are part of a larger team, and your efforts and your accountability is ultimately what drives things forward. And pharmacy is a very similar, representation of what team-based healthcare can be. And knowing that as a pharmacist, you have such an important role and such impact on patient care, but you are also working within a larger healthcare team. And what we do as pharmacists every day only serves to improve the health of the individual as it relates to how they see everybody else as well. So it was really, I think a lot of what I do now and the path that I've taken, as we'll allude to a little bit later, is really so highly defined by learning about teamwork and being a part of a team, and that it's about more than just one individual person.
Yeah, I was in sport myself. I was a runner, and even though I was an individual, I had competed individual. You're never just an individual, just like the pharmacist is just never just the pharmacist, but you have all these people that you're supporting as well as the other people that are supporting you. So there's a lot of good ways that we can use sport in our work site. So you entered pharmacy school. Was it what you expected?
Honestly, it wasn't, but that's in a good way. I joke with a lot of people because I know graduate level programs can be very stressful and can be very difficult for a lot of people. And there's often a time where you need to come to the decision of, you know, am I doing this for the right reasons? Is it exactly what I wanted it to be? And admittedly, in those first 2 years when I was in pharmacy school, it was before we even hit the pharmacy curriculum. It was more of our undergraduate level courses. I was having those same thoughts. It was a very rigorous coursework. I came from a very small public school that didn't have an incredibly rigorous education. So I went in rather unprepared at how to study and how to function at a high level aside from what I had already done in my high school experiences. So there was a very small period of time where I was actually reconsidering what I chose before I even hit the pharmacy component of things. But really, once we progressed into the pharmacy curriculum, it became, I don't know, more than what I was expecting. From my very small community pharmacy perspective, I had a very narrow focus and narrow understanding of what pharmacists could do. I went into the pharmacy school with the assumption that I would go through the curriculum, I would graduate, I would work for a community pharmacy for the next 50 years. I would retire, and that would be my career in a nutshell. And the more that I learned from mentors, from other students, from just the experiences, was the vast capabilities of pharmacists and all the different avenues that they can use to help patients. And that ties so much back to what I was talking about in high school, that there's more than one way to help somebody. And I think what I learned very early on in my pharmacy education is that there are so many different ways as a pharmacist that you can help people. And I found myself becoming more gravitated towards non-traditional pathways for pharmacists.
So sometimes we'll get early workforce or people that are considering a career in pharmacy. What was it for you, Nate, that pushed you, said, instead of pushing you away from pharmacy, that pushed you closer to pharmacy and on the path that you're on now?
Yeah, really, it was relationships with patients. When I was able to get into a community pharmacy and start working as an intern about halfway through my pharmacy career, the most rewarding aspect to me was to learn and to understand patients, their families, and their greater context within the community that they serve. I owe everything that I have in pharmacy to my first pharmacy job in a very small town about 30 miles from where I grew up. And the support and the guidance from the pharmacist that I had there is probably unmatched to anything else I will experience in my professional career again. He was a young pharmacy graduate, probably about 7 or 8 years older than I was. And it was a small, like, mom and pop pharmacy. The pharmacy was his father's, and then he was in the process of taking it over from his father. And he had all these great ideas and a lot that he wanted to do with the pharmacy for his patients and for his community. But being such a small town, we were always hampered by the amount of help that we could get in the pharmacy to serve the community. So he was always incredibly supportive of the ideas I brought, still being in my educational career, and the things I was learning about and what we could do for patients. And it was just the most supportive environment, the getting to know the patients, to know their struggles, to know their motivations for their healthcare, and to figure out where we as a pharmacy could help bridge the gap between where they were, but ultimately where they wanted to be. So really, as much as I love the concept of medication use and I love the ability to know what is the right medication for somebody, the far greater reward for me is knowing the patients and getting that relationship building and the understanding of, if we have to use medications and we have to do certain things, I feel more at a place where I can help because I feel like I understand them on a deeper level about what is exactly involved in their care.
So you want to give a shout out to that early mentor to you? What was his name?
Yeah, so his name is Larry Shanley. Yeah, he's still practicing back in northern New York at an outpatient hospital pharmacy. So unfortunately, I don't get back home as much as I would like to see him, but I couldn't thank him enough for really putting me on the path of what it means to put the patient first.
That seems to be a theme for you as we've talked about this. So you started in pharmacy, and then you did this. You got this specialty. Talk a bit about that. Tell us about that.
Yeah, so in pharmacy school, and kind of relating back to what I was just talking about in the pharmacy, the developing the relationships is obviously one of the most rewarding aspects of it. But for me personally, I felt like working in a community pharmacy that I didn't have all the information that I needed to best care for patients. So patients would come in to pick up medications and we would dispense them. And as best we could tell, it was safe and it was appropriate. But most community pharmacies don't have access to all of the patient's lab work, to all of their chronic conditions, to even all of their immunizations. And for some patients who use multiple pharmacies, potentially even all of their medications. So for me, I always felt like I wasn't 100% confident when I gave out a medication that I can say this is the right med for you because I don't have all the information. So what I was, fortunate again, and you'll hear this theme come up a lot. I've been very fortunate to have just incredible mentors who have shaped my path really to what it is now and what it's going to be in the future. But I had mentors who practiced in family medicine. So this is where the concept of a primary care pharmacist really comes to light, is the ability to develop relationships with patients in a clinic setting, much like a primary care provider would, but then also be on that side of healthcare where you can see labs and you can see chronic conditions and you can start putting this whole puzzle together and really figure out what is the best medication. And if this is not the best medication for them, what else do we have? And I use the term best very loosely because it could be best in terms of how well it works. It could be best in terms of how expensive it might be, or it could be best on just how accessible it is for that patient to get a certain medication. So I use the term best very loosely because there are so many different ways as a pharmacist we can impact the medication use of patients from whatever perspective they need it.
So let's talk about that. I am interested in this idea of it being like a puzzle, and it fits with what you were saying about this team. Let's talk about family medicine and medicine in general as a part of that puzzle with that patient and pharmacy. How does that work?
Yeah, so it really depends on where you practice, but to speak specifically to mine, and to really kind of now bridge the gap from my college education to my residency education in Pittsburgh, it's really about patients who get referred to a pharmacist for disease states or for medication issues that are uncontrolled. So for example, a pharmacist could inherit a patient in a clinic setting who has 15 to 20 medications. It's a very complex regimen. And we're just really trying to do an assessment of, are they the right medications for all the different chronic diseases? So kind of a comprehensive overview. We call that in pharmacy a comprehensive medication review. Another way a patient might get to a pharmacist is if they have an uncontrolled chronic illness. So we're talking about diabetes or high blood pressure, high cholesterol, breathing problems, people who want help with smoking cessation. That's another way a patient gets to a pharmacist in my setting. So when I liken it to a puzzle from the standpoint of, we teach students, and I learned as a student, that we have evidence that tells us what we should be doing. But each patient is so unique, and the guidelines don't apply to every patient in the exact same way. So the puzzle therein lies where you inherit a patient who is having difficulties managing a chronic illness. So the first part of the puzzle is figuring out, what makes it difficult for somebody to manage their illness or manage their medications. But then the second part of the puzzle is, once you figure that part out, figuring out where can the evidence about what we know is right fit in with what is right in the patient's life. So finding that intersection between what we know to be appropriate, but also what is most appropriate for that particular patient at that time in their care.
Give us an example of that one, if you have one for us.
Yeah, so one ready example that pops off the top of my mind is in my current clinical practice, we see a lot of patients for diabetes management. Mm-hmm. And a great concern for a lot of the patients that I serve is financial concerns. And it's no mystery or it's not unknown that insulin is a very expensive medication for a lot of people, even with their insurance. So, I mean, unfortunately, I can count on many hands the amount of patients that I've inherited into my clinic to care for who are on insulin who just cannot afford it. But their diabetes, unfortunately, is so difficult to control that we don't have a lot of other medications that work as well as insulin does. So one of the things that I've been able to do for patients is to figure out which insulin options are affordable, and then figuring out how to transition them from the type of insulin they're on now, which is not affordable long-term, to a more affordable insulin, and to work with them on adjusting the dose and really following up to make sure that dose gets adjusted in an appropriate way. So I would say one of the largest things that I help with is just affordability of medications. And that comes from the setting of, if you look at guidelines, it'll say patients with diabetes of a certain level should be on insulin. So they get started on insulin, but it's never really followed up. Like, how well can you afford it? Are you sacrificing food? Are you sacrificing shelter or home care to pay for your medications because you feel they are that important? So I've had patients change from one insulin to another. Patients who spend $200 or $300 a month on insulin are now spending $30 to $40 a month. So they're able to save an extra $150 to $200 a month that they can then use to prioritize other personal considerations or family considerations.
That's huge.
Absolutely. And that's, it's every patient's unique, but a lot of our patients have the same concerns and the same issues. So just that very small ability to put another $100 to $150 on the table of our patients to have them decide what is best for that is monumental.
Did they teach you that in pharmacy school?
Sorry, can you repeat the question?
Did they teach you that in pharmacy school?
Oh, I feel like they tried. And I say they tried because when you're in pharmacy school, and I'm sure any pharmacist or any graduate level healthcare provider that's viewing this will say that graduate school is like drinking through a fire hose. And, there's so much to absorb and there's so much to process that when I was a student, to me, it was about, okay, say the right thing, make sure what you're saying is right, and not really focusing on how I say it or how I ask questions or how I, listen to understand versus listen to just respond. So in pharmacy school, you're taught how to do these things, but it's so hard to do them all together that you tend to silo your focus. And it really only comes with more experience and more practice in one particular area where it becomes less about thinking and more about understanding. So we do as best we can as educators to teach our student learners and our resident learners how to do these things, but it just takes time and it takes experience, and it takes the experience that really will change one's perspective from what they know. And I say that very intentionally because going back to my early childhood story of the village and the community that I grew up in, it was not diverse. It was probably one of the most geographically least diverse areas in the US, right up next to where I grew up in Vermont. So I say that from the perspective of, we didn't have any African-American patients or any African-American students in my entire high school. We had a few Latinx people that I went to school with, but really it's not geographically or racially diverse up there. So I say that because my intention, when I realized that my experiences did not suit me well to care for all patients, because I hadn't cared for patients of an urban setting or patients of African-American, Latinx, or even Asian descent. I didn't have those experiences, so I knew I needed those experiences. So I was very fortunate when I was looking for residency programs to give me more of those experiences, to find programs that focused on urban underserved patients. And through those experiences, I was able to gain a better understanding of what really are the issues that our urban patients face compared to the issues that I already knew very well about what our rural patients faced.
I really liked what you said a moment ago, Nate, this idea of you listen to respond when you're early in your career, and then later on you listen to understand. Mm-hmm. What's the difference?
So as a student, you're listening to respond because you know what you need to say and you know what's appropriate to say. So you're just waiting for the patient to say anything. And then once they say it, you know what you need to say next, because you follow a rubric, you follow an outline, you know what you're supposed to say. But because you're so eager to say something, you don't think about what the patient just told you. So for example, when I was a pharmacy student and I was on one of my clinical rotations, we were seeing a patient who wanted to stop smoking. So that's one of the lowest hanging fruits for a pharmacist to help with, is a patient who wants to stop smoking. And we were seeing a patient in a clinic setting. And once I heard it was about stopping smoking, I knew exactly in my head what options we have available. And as the patient's speaking, I'm kind of like going through like, which one do I want to use? Which one looks best? And I completely glossed over the fact that the patient said she had dentures. So she was talking about how it was difficult to choose certain foods, and how when she stopped smoking before, she ended up eating a lot more and gained a lot of weight, and then she went back to smoking because of stress. But in this whole thing, she ended up telling me that she had dentures. Completely went right over my head because I was more focused on what can I tell her is going to be a good option. So we started thinking about nicotine replacement therapies like patches, gums, lozenges. And I was like, oh, the gum will be a good idea. And part of it was because it was situational for her. She would identify, she'd get stressed, and she'd want something to do. So I was like, a gum is perfect because you can chew the gum once you feel that anxiety, that stress coming on when you otherwise would smoke a cigarette. Well, I called her about 3 days later to follow up and see how things were going. And I get a hold of her. And the first question I ask is, how has the quitting smoking been? And she's like, oh, it hasn't been so good. And I was like, oh, why is that? And she proceeded to tell me that when she was leaving the pharmacy, she popped the first piece of gum, and unfortunately it got stuck in her dentures, and she couldn't get it out of her dentures. So then when she got home, she was without dentures for 3 days and hadn't really been able to eat much food or do much of anything else because she had no backup dentures, and she had to wait for the replacement pair to come. So that is in a microcosm of what I say when you listen to respond, because as a student, you really want to get it right, and you want to give them a medication or a treatment that's going to work. But as you get more experience and you listen to understand, we pick up on the fact that dentures are probably not a good idea for somebody who needs to be chewing gum. So we probably would want to consider something else. So that's kind of a satirical story too, from the perspective of it's not like that's that way for everybody who has dentures, but it really highlights the focus that, when you listen to understand, you have in your thoughts what you want to do, but is solely dependent upon what the patient is providing and what works best for the patient at that particular point in time.
I've heard other healthcare providers, and we'll leave it at that, say to patients, well, why don't you just do X?
I cringe. I'm sorry. I cringe when I hear that. And I've seen that so much too.
You know what? I continue to hear people that listen to respond, even with 20 years experience. Now, I want to go at this route. What shifted for you about how you wanted to understand? Because you said something that was quite interesting. I didn't have a lot of experience with people of color, and I wanted that. You were hungry for that, and you were humble for that. So you knew what you didn't know, and you wanted to get those experiences. What happened?
So very admittedly, it was a few of the patient encounters that I had when I was in my community pharmacy as a student. So some of the towns close by had African-American patients, and they would frequent our pharmacy. And I was uncomfortable about the fact that I was uncomfortable. When they would come to the counter, I didn't feel like I could relate very well, because my entire experience up until then had been around, Caucasian patients. And it left me wondering, why do I not feel as suited to care for patients of African-American, Latinx descent? And it really boiled down to, I had never experienced what their struggles were and what their daily kind of lives entailed, because it just wasn't a very common experience where I came from. So it was really just my uncomfortability, being uncomfortable with those types of patients, that I wanted to be better. I didn't want to be uncomfortable. I wanted to know that whoever comes to the counter, I have a way that I can relate. And I will never fully understand, because I have not come from the same background as a lot of our patients, but I want a better appreciation for the struggles, for the culture, for everything that goes into their daily lives, because I cannot possibly be the best provider for them if I don't at least have an appreciation for their daily lives and what they go through, and really what matters to them, whether that's family, friends, well-being, you know, X, Y, or Z, whatever that might be. So really, it was a turning point where I just realized that that's not the way to be a healthcare professional if you can't relate to your patients, of any patient that walks through the pharmacy door.
So now you have it all figured out, right?
Oh, of course. Yeah. No, it's definitely an evolutionary process. And what I've recently focused more of my attention on is the LGBTQ community. So really, as I identify patients in communities that I am unfamiliar with and just don't have a lot of experience caring for, I want to be a better ally and a better teammate for those communities to help them access healthcare.
You know, I was saying that tongue in cheek, which I knew that you were, but I want to be clear to the audience that we weren't serious about this because I identify as a white male, and part of that white male means, you know, there's a lot of white supremacy that goes on. There's oppression of people by people that look like me. I've worked with enough communities of color to know that you never quite have it figured out. But if you can find those guides, those people that are from that community, that understand the culture, that can be willing to guide you. I have a partner who says, Nelson, I want you to be successful. And so when you say things like this, it's offensive. And I know you don't mean to be offensive, but let's see if we can do better.
Yeah.
Did you have such a guide for you, Dr. Lamberton?
So I did, but it wasn't, early on, it wasn't anybody from the community. So my guides were really the providers of the clinic where I was doing my residency in Pittsburgh. So even in Pittsburgh, in the underserved areas of, the area was Bloomfield, Garfield is one of the neighborhoods in Pittsburgh. A lot of the providers there are predominantly white as well. But their office staff and their medical assistants and nursing staff were African-American from the very same communities they served. So I got the perspective of somebody who is a white male healthcare professional caring for patients of African-American descent, and what it's like to have that transition in your understanding from people who had experienced very similar transitions in their own career, but then also from the medical assistants and the nursing staff who were African-American and were from that community, who could share what it's like to be a patient coming to that clinic because they work there, but they were patients of the clinic. So I was, you know, very fortunate again to have kind of leaders on both sides to help me better in that process of transitioning my understanding, but then also from the patient perspective in a very safe environment, because, you know, they know that we're here to help and we're there to understand better, and where we can do a better job and where we can use more appropriate terminology and a more appropriate understanding is what they were there to help with. And that's why before I use the term a better appreciation, because I know there's no way I will ever fully understand what it's like to go through some of the struggles that our patients go through and to walk, you know, a mile in their shoes. But I want to have a better appreciation for what my patients are dealing with and the concerns that they have, so that way I can better care for them too.
Yeah, you know, I'm certain that you're not the only one. If you take what your patients say seriously, that they will be glad to teach you. They will be glad to show you, because you want to do so, not to take advantage, but to learn from them and how you can best, you know, figure out what the pieces of the puzzle look like.
Yeah.
So you came here to the medical college, which started a pharmacy school a few years ago, and you were really early on in that process, weren't you?
Yes, I was fortunate enough to be one of the founding faculty members. So I started a month before our inaugural class started.
Talk about that.
That could be a whole separate hour-long podcast about the transition as a young professional to education. But it was really the allure of a pharmacy program embedded within a medical program. So bringing back that whole team-based care, interprofessional care, the ability to be a part of a program that trains medical and pharmacy students side by side to emulate the same model that I found as a passion in my pharmacy education. But then really, and highlighting the second, aspect of what we're talking about in my clinical practice was the opportunity to join a family medicine residency program and be, fortunately, the inaugural clinical pharmacists with that healthcare environment as well, and to develop what clinical pharmacy services could look like in that clinic. So it was really just an incredible opportunity to take all the experience I had been acquiring through pharmacy school, through residency, and then put it to use in creation. And it's a tall task, and in some ways very daunting to think about it in that perspective, to come fresh out of residency at, oh boy, like 26 years old at that point, and then to try to develop educational models and educational materials for people who have committed their time and their effort to our program to help us see them through the program and develop the same experiences. So it was really a great opportunity to be a part of something as you create it, to mold it into what you think is most appropriate.
Dr. Lamberton, you don't look like a pharmacist faculty. I'm just gonna say it. Do you have any stories about students saying, wait a minute, who is this young guy up there?
Oh boy, I have many stories, even back to residency. But one of the most recent stories that I share with everybody, because it's hilarious, was when our inaugural class started. One of the things we tried to do was like a little mixer at a local pub where, you know, we cordoned off like one of the areas and had like drinks and appetizers and whatnot. And I show up after, you know, a long day here, and all the students are just gathered around various kind of standing tables, having drinks and getting to know one another. And I decide I want to join one of these conversations, but I joined mid-conversation, so there wasn't a great time to introduce myself. So I just kind of, you know, walked up to the table and started talking. And I talked with maybe 8 or 9 students for about 30 minutes before the introductions finally happened, and they found out that I was a faculty member, and the conversation got very quiet very quickly. So yeah, it happens all the time. Or if I'm seeing a patient, they'll think I'm a pharmacy student before we get into a little bit more of the deeper introduction. So yeah, it happens quite frequently, and you know, everybody tells me that I'll appreciate it someday, but I don't know. I haven't hit that point yet. So
it is always funny when, you know, it's when they start calling you sir that you know that you've reached that point where you're no longer one of them.
Yeah.
Nate, I want to talk about chronic disease and this idea of the community context.
Yeah, absolutely.
Talk about your experiences of working at the family medicine residency. Give us talk about the setting, what type of patients you're seeing, and just anything that can help set that stage about how we can talk about chronic disease management.
Yeah, so I said this a little bit earlier too, like every patient really is unique and we have unique struggles, but what you start to see over and over are themes, and what themes tend to prevail with patients of an urban kind of underserved status. So patients that I see typically in clinic primarily are African-American patients, as is, you know, the true of the surrounding area of the clinic too, is heavily African-American descent patients. Primarily middle age. So I would say anywhere from the ages of 40 to 60 are probably where most of my patients will lie. And then really for patients, when we talk about uncontrolled conditions, we're thinking mostly diabetes is what I see. So in my clinical experience as a resident, and even in pharmacy school, I was really gravitating towards the care of the patient who has diabetes. And I'm very particular about not saying diabetic patients, because diabetes does not define somebody. So it shouldn't be a qualifier in front of their name. So that's one of the things I'm very passionate about, is diabetes and how it relates to patients, because that is so multifactorial, and medications often are very small portions of what we can do to help patients with diabetes. So I'm sure it sounds potentially odd for some people to think that a pharmacist enjoys a disease state where we focus more on lifestyle than we do the medications that we use to treat it. But it's always been, you know, the importance to me is, if we have to use medications, what are we going to use? But really, what else can we do to help patients from a diet perspective, from physical activity, or just lifestyle perspectives, before we even get to the use of medications? Because really, that's just kind of like putting a Band-Aid over something and not really fixing the reason why somebody develops diabetes. So that's primarily what I deal with for chronic conditions. But along with diabetes, patients also have high blood pressure, high cholesterol, potentially asthma or COPD. So even though we see patients for a primary reason of diabetes, we're always focusing on their comprehensive health and all the other factors that contribute to their overall health in addition to their diabetes.
Is the industry aligned like this, or are you unique in your aligning this with lifestyle?
Yeah, so it really depends on where you go. And I say that from the perspective of certain geographical areas have either more or less opportunities for pharmacists to engage in roles such as myself. And there are pathways for pharmacists to become certified diabetic educators, or even board certified advanced diabetes managers is another certification you can get. So there are avenues that allow pharmacists to get those additional credentials that will highlight their skills in these areas to be able to do very similar things. But you know, it's hard to say where it is elsewhere, because I feel like I've had incredible training and it's always been well ingrained into my development that lifestyle changes and you know, psychosocial understanding of patients is the best way that we can help patients get to their health goals, and that medications are there to help, but they are not the curative. There is no cure for diabetes. So we do those to help mitigate, but really focusing on behavior changes is where we place a lot of our focus.
So let's go into an example. And you talked about this comprehensive medical review, but let's talk about this idea of someone that comes to you that has been diagnosed with diabetes and you're seeing them for the first time.
Mm-hmm.
Some of our listeners will have never experienced that. And so what do you do when you meet with a patient for the first time?
Yeah, it's actually, I say it's kind of like a guideline that I follow. I always talk about the same things, but I talk about them in the order the patient chooses to talk about them. So with anybody who has diabetes, there are fundamental things we always need to understand. So there's really kind of a checklist that we need to go through just to make sure we're collecting information. So the first time I see a patient for diabetes, I'm very forthright and I say, the majority of this visit, they're going to be talking. It's a lot of sharing their story, their information. And really, before I even get into diabetes-related questions that I ask them, the first question I ask is, you know, tell me about your story with diabetes. What do you know about it? What has that journey been like? And just kind of lay it all out for me. And in that 10 minutes or so a patient usually takes to talk about their diabetes, they probably answer 95% of my questions. Because really, I'm not going to sit in an office and try to tell somebody how to best manage their diabetes if they don't even know what diabetes is. So I feel like we really need to do a better job of understanding what patients know about these chronic conditions. Because if I say diabetes, I've had patients think that's their cholesterol. I've had patients think that's their blood pressure. They don't even know from a basic standpoint that it's blood sugar. So how can I talk about blood sugar without first telling them or working with them to understand better what diabetes is and why we as healthcare professionals care so much about it? So that's always where the conversation starts, is having the patient tell me what they know about diabetes, what's going on in their body, and why do we care so much? And then from there, it can take on many different pathways depending on their response and what the questions are. But further from that, we always talk about their medications. So obviously, as a pharmacist, we focus a lot on medication use and medication use behaviors. So what medications are they currently using? And then more particularly, how are they using them? How many tablets are they taking, or how many injections are they doing? Where are they storing medications? How affordable are their medications? How often do they potentially miss a medication? So we're getting to the heart of patients who don't use their meds and people think they are. And then from there, we always talk about what motivates patients. And I think this is probably one of the greatest avenues we have as healthcare professionals, is to figure out what motivates our patients to want better health. If we can't understand why a patient cares for their health condition, there's nothing that we can say that will make them care. So that's a very much a shared conversation to figure out what matters to them and what's important in their life, and why managing diabetes will also coincide with that importance.
I'm going to go back a little bit.
Yeah.
You had said, so someone comes to you and you're reviewing their chart and their story, and they think diabetes has to do with their cholesterol.
Mm-hmm.
Where's the disconnect?
Unfortunately, I think the disconnect is potentially in just their understanding of biology. I mean, we think as healthcare professionals, because we see it all the time, we think it's a simple concept. But we need to remember that all of our patients have different educational statuses. Some probably didn't even progress past grade school. So how are we expecting them to manage these medication regimens of 20 medications long for somebody who just has a very limited literacy level, let alone a health literacy level. So I think the disconnect comes at the point of diagnosis. So at any time somebody gets diagnosed with an illness, it's a life-changing event. And we talk about this a lot with our patients. I mean, diabetes, managing it as a patient is a full-time job. You're thinking about your exercise. You're thinking about all the food and the meals you eat throughout the day. You're thinking about all the medications you take. You're worried when you go out somewhere, what if I have low blood sugar and I don't have a way to treat that? So being diagnosed with a chronic illness is a very life-altering event. And it's a lot for a patient to take in all at once. So I think what we need to do as healthcare professionals is to continually revisit a patient's understanding of their chronic illness.
Give me an example.
So, for example, patients that I see, because I can relate best to what I do with patients, but also what I've seen other physicians, is that as a pharmacist, I don't diagnose patients. So I see patients who have been diagnosed and are referred to me with a diagnosis and looking for additional help with treatment regimens. So with my patients, I always revisit the first visit, tell me what you know about diabetes. And then we'll have our visit and we'll progress to the next visit and then we'll revisit. What does diabetes mean to you? And I say it very specifically because I don't want them to just parrot back what I told them last time. It's more about, in your own words, can you explain to me what diabetes is, or what high blood pressure is, or what high cholesterol is? And it's really one of those things that I'm passionate about, and it's about improving health literacy for patients. So although we often avoid what we'll call medical jargon or overly complex words that are difficult for patients to understand, I totally support that we need to talk to patients at their level, but I'm also a supporter of improving health literacy. So bringing back these complex terms over and over and over again and relating them into terms that patients understand, so that way we don't perpetuate low health literacy, we help to improve health literacy. So over the course of seeing patients, I consistently revisit educational topics we've talked about before. So whether that's diabetes, whether that's treating low blood sugar, whether that's some sort of dietary understanding, it's just really about that repetition that we can have with patients to ensure, especially for these really big sticking points that are really important to managing diabetes, really figuring out, is the patient able to absorb and then talk about it in their own words? And if they're not, then there's a disconnect and we need to explore that more. Because if we're having disconnects on some of the more simple concepts about diabetes, my greatest concern is that we'll have a disconnect about something that's a little bit more complex and might lead to potentially some patient harm in some way.
So is that the stage of what you might be looking for, is when the patient can talk about it in their own words?
Yes. I mean, it's hard to quantify or to evaluate what understanding means, because there's varying levels of understanding. But really, to me, my goal is to improve the patient's understanding enough that they can tell me in their own words basically what's going on. And then even further from that, to be able to tell me what's going on and why they're motivated to now control it.
Let's talk about that idea of, you talked about motivation. Talk a bit about that, what it means, and how you gauge that in someone.
Yeah. So motivation is a very vague kind of generic term. And I emphasize that a lot because it goes back to what you were saying before, if you just did this, things would get better. And that does nothing to understand why a patient cares. So I will tell you, the majority of patients that I see who I ask, why we care so much about diabetes, their number one response is they don't want to lose any limbs. So they know family members who have had amputations. They know that, you can have limbs cut off and that you could potentially die. But negative consequences are not strong motivating factors for people. People don't act because of things they don't want to happen. They act because of things they do want to happen. So what I want to find out is what matters to them. What do they enjoy doing? So for example, I have a patient who really enjoys painting. And when I say painting, I mean like construction painting. So painting rooms, painting murals. It requires him to get up on these 14 to 18 foot ladders to be able to paint and whatnot. So for that particular patient, once we were able to figure that out, we were able to then talk about his diabetes in a way that by managing his diabetes, it would allow him to keep doing that. So one of the long-term complications of diabetes that we know about is potentially losing sensation in your feet and in your fingers. So it would be unsafe for somebody who has that potential complication to go up on an 18-foot ladder who's unsteady, and then the ability to paint fine details on a mural if you're having what we call neuropathy, or burning, tingling sensation in your hands and your feet. So when we related to him in that way, it became much more of a motivation to not want that to happen because he enjoys painting, versus telling him or working with him, someone who's already had significant family complications from diabetes, unfortunately lost a father, who had a long battle with kidney disease, ultimately dialysis, who had a heart attack and passed away. Those things didn't matter to him. He didn't want to change because of what he thought negatively was going to happen, because for him, that's all he had ever seen. All he saw were his relatives having complications from diabetes and unfortunately not being able to manage them. So if we put it in a different light of a positive perspective, that he can continue painting and keep doing what he enjoys doing by controlling his diabetes, then it becomes a much different situation for him.
What happens then?
What happens then is we have a much more, I would say, a much more meaningful conversation. And I think as providers, you obviously you go through the visit and you do your best job, but you're always thinking, I haven't really connected yet. Like you can tell when you really make that connection and you're understanding each other, and there's that mutual understanding. And once that happens, then the conversations take a very different turn. And I think from the patients that I've seen, even the ability to ask more questions about what matters to them develops a different level of trust. And I think with that different level of trust, we're able to have conversations that lead to more changes, and whether that's behavioral or medication changes, there's really just a different level of buy-in into what we're working towards, because we're doing it together. And it's not me telling somebody, you should do this because you will die eventually. Like, that doesn't mean a whole lot to a lot of people, because that, for a lot of patients with diabetes, is 20 years down the line. It's hard to have that forethought about 20 years from now, I might die from something I'm not doing today. But 5 years from now, I might not be able to paint from something I'm not doing today. So we're also helping them build some of these more connections than we are just telling them about what might happen.
Do you think, Nate, that there's some fear and stigma from those patients who just don't get it?
I think in certain circumstances that definitely prevails. And unfortunately, I've cared for patients who, I don't want to put this on them because they've never said it, but I'm concerned that they have what I'll call like some sort of fatalistic outlook of diabetes. Their parents have had diabetes and passed away. Their siblings have had diabetes and passed away. And if that's all you've ever seen, how can anybody tell you to expect something different? So unfortunately, from that perspective, it's been a very difficult road for some patients who have just not seen anything except unfortunate outcomes from those loved ones who have had diabetes. So what I say and what we try to work on just has a very different meaning, because they've never seen somebody be able to manage it and to have positive outcomes. And the stigma is a very interesting one as well. And I think about stigma from a bunch of different perspectives, not just the stigma of having a chronic illness or what having diabetes, what other people might perceive about you, but the stigma of somebody who has to tell a provider that they're using medication because they don't want to say they can't afford it. And to me, that hits near and dear to my heart for the patients who can't afford medications, but otherwise want to, they want to be the good patient. They want to use medications because they know that it's going to help, but they have to admit they're not using the medication because they can't afford it. And because they can't afford it, they're prioritizing their funds on groceries, on electricity, on shelter, on, you name it. And it's unfortunate that patients feel that that's the case and that there's a stigma associated with that part of it too.
So I'm going to put that on us. And I've noticed this in other conversations that I've had, that we are often in the healthcare space. And though I'm not a provider, I both work in the field. I'm married to a physician and work at the medical school. Why are we reluctant to have these conversations and to have this understanding from the health space, whether it be on food or housing or any number of issues, as opposed to it shouldn't be a choice of food or medicine. But why is it that we can't have this conversation?
Well, I mean, the most obvious answer is it's a difficult conversation to have. And from my experiences, once you have the conversation, then there needs to be some sort of solution or some sort of outcome. And I feel like a lot of individuals, they just don't have the understanding of the resources or the avenues we have to help patients who express these concerns. And secondly, and you know, I'm ashamed to admit it, is that time. These conversations can't happen in 3 minutes either. So we think about the very short appointment time slots for our patients, sometimes 15 minutes to assess 3 chronic conditions, potentially losing their house. But you think about all the social stressors, how can you possibly have a meaningful conversation about somebody's food or income insecurity in 3 minutes? So I think it's a combination of there's unfortunately just not enough time to devote to that to make it meaningful, but then there's a lack of awareness or understanding of what resources are available to patients who might have concerns in any of those insecurity areas.
So suddenly you're giving the power to make those changes. What would you do?
Oh boy, that is the million, potentially even billion-dollar question when you think about revenue to healthcare systems when we see patients. And being a pharmacist in my role, there is no direct reimbursement for what I do. And I'm very open about that. When I see patients, they don't have a copay for seeing me because there isn't the avenue for pharmacists to get paid within, you know, the current economic slate and potentially healthcare slate. But that's not to be said that there aren't indirect savings from pharmacist services. And I say that to prelude back to our other conversation, that having these conversations with patients provide indirect healthcare savings. So you have the conversation with the patients, you give them 25 minutes instead of 15 minutes, and you're able to have that conversation. And now when their power goes out, well, one, hopefully the power doesn't go out because you've been able to connect them to the right resources. But then two, patients whose power does go out in the winter generally go to the emergency department or someplace that's warm. So you're saving the healthcare system money because the patients are not going to other avenues of healthcare with their insurance to be cared for things that don't necessarily need, you know, healthcare. And that's, of course, it's simple, but it's not easy. And that's something we'll always come back to in healthcare, is that obviously these places need to be able to operate. So we need to have revenue from some perspective. But I think we as a healthcare society need to focus on the indirect benefits that some of these services, including pharmacy, can provide, and then ultimately leverage that into some of these direct benefits by allocating appropriate amount of time. And then even for my services, as you know, a non-reimbursable service that I provide, my schedule is quite limited. So I can only see so many patients per week and so many patients per day. And I see patients every 40 minutes. So I have that time to dedicate to get into some of these deeper issues that they might not otherwise have. So of course, there are so many solutions, and you can scour the healthcare landscape for other solutions as well. But just a very quick one is just thinking about the indirect benefits that a lot of these programs can provide. And it's difficult to measure, so that's why it's not as readily done.
You know, you were talking about this idea of understanding, not just to respond because you know the answer, but going to understanding. And you keep talking, I use the word trust, I have the word relationship here. And in essence, you're creating a relationship with the patient based upon what that patient's needs are. What an innovative concept, Dr. Lamberton.
I know it's groundbreaking, but really, and I say that obviously, you know, joking as well, but you know, I love the term that it's simple but not easy, because it really gets to the heart of there's an answer for everything, but it's not always easy to do what we want to do. And going back to the mentors that I had in pharmacy school, the first thing I was told on one of my clinical family medicine rotations was a quote by, I believe it was St. Francis of Assisi, is seek first to understand, then to be understood. And at the time, I enjoyed the quote. I thought it meant a lot, but I didn't really have experiences to justify it. And I think that has ultimately, from a practice management standpoint, shaped the most of my clinical practice more than anything else that I've experienced, is just learn, like listen to learn, to understand, to probe when I have uncertainties about a patient, and don't ever assume. So really that's something that I try to share with any healthcare provider, whether it's a learner or a colleague that I encounter, is that we can't help care for somebody if we don't understand them. And that's really shaped a lot of what I do. And that's why I bring back trust. I bring back relationships, because that quote at its foundation is what helps to develop that trust, to build those relationships, because you're taking a genuine interest in your patients. And, I'm not here to say that providers don't do that, because I know there's a lot of great relationships between primary care providers and the patients, and that trust is there. But I think from a pharmacy perspective, there's a different kind of trust and a different ability to get that in a shorter amount of time when you have 40 minutes to spend with a patient as opposed to 15 minutes. And I can see a patient every 2 to 4 weeks versus potentially 1 to 3 months for somebody else. So we're able to develop those relationships fairly quickly. And the most productive way to do that is to be a team in their healthcare and not patient provider.
Yeah, so it is that idea to again, to go back to understanding. And yet too often we get into the space of time and having to hurry through. And so we don't take the time to speak into, do you have enough food, or do you have electricity, or what concerns do you have about your family or your community?
Mm-hmm.
I want to switch a little bit, but I want to bring it into the modernity of the modern times of how has the pandemic that we're in currently impacted your work?
Yeah, quite significantly, but in ways that I didn't really anticipate that it would. So it would also be difficult to have this conversation without also mentioning a small part of my role, or it's actually quite a large part, but we haven't really talked too much about it, is as the pharmacy director for the Saturday Clinic for the Uninsured. So the free student-run, interprofessional student-run health clinic that operates on Saturday mornings. So I bring that up in terms of that question because we have a lot of patients who unfortunately lost their employment when the COVID pandemic became quite prevalent here in the US, and because of that, no longer have health insurance. So from a free clinic perspective, we are now seeing a lot of patients as new patients to our clinic who otherwise used to have insurance but no longer do. So we're doing a lot of primary care services for patients in our free clinic. But then also a big shift has been now towards what we call telehealth. So the ability to see and work with a patient through some sort of virtual technology, whether it's a video conference such as this, or whether it's over the telephone. And in some respects, it's improved our ability to reach out and connect with our patients. And I say that because a lot of our patients do not have a primary mode of transportation. It's either the bus, it's Lyft, it's Uber, it's a taxi, it's some sort of public transportation, which for some of our patients, they take 4 different bus lines to get to us. And it's a very significant barrier. But the ability to call a patient who's comfortable in their home or their place of residence and to have these meaningful discussions and still make improvements in their chronic diseases is of the utmost kind of priority at this point. So, for all of the negatives that the pandemic brings on our community and the unfortunate loss of life and the loss of job, for certain patients, it has actually improved our ability to reach out and connect with them and start managing some of their chronic conditions virtually. So it's been, in that respect, a really good opportunity for me particularly to reach out to some of the patients that we just had difficulties getting to clinic because of transportation issues, potentially scheduling issues. It's really been a great opportunity to reconnect and to really refocus where we prioritize, our focus in their healthcare. The kind of tangent of that, and something that I was not really expecting, but I just saw a patient a couple weeks ago where he explained this to me, is that he got the stimulus check. And that was the largest check he had received in years. So he spent that money on food that he enjoyed eating versus the food that he could only afford previous. And his A1C, so his long-term measure of his diabetes control, almost doubled in the 3-month period from when he got that stimulus check. And, it made me take a step back and realize that the stimulus check that he got, he put entirely towards food because he had been sacrificing, in his mind, the food he enjoys eating for what he could afford, but was also good for his diabetes. So it now makes me take a step back and realize for the other patients I'm seeing, how do they prioritize that money? Because that is a very significant amount of money for patients who otherwise live on very limited means. And it's really, interesting to probe how they're using that and where their priorities lie, because when they get that money, the first thing they spend it on is obviously where their priorities are. And I think it's better for us to understand, you get this sum of money, what do you do with it? And what are you buying with it? So that was a very unexpected outcome of what came of the COVID pandemic.
It would be easy in that space to be condemning of an individual, as opposed to saying, hey, we understand that, you know, you've not had a lot of money in the past, and so this is a way to be good to yourself.
Mm-hmm. Exactly. And part of me after that visit, you know, I felt, I can't describe what I felt, but I just felt bad, I guess is the best way to put it, because the patient, he appeared embarrassed, he appeared distraught, because he knew it wasn't right, but it was what he needed mentally to be able to do. And it tore me apart to have a patient who feels ashamed about what they did with the money that they felt was best for them. And I felt so unprepared for that encounter, because I was not anticipating that discussion coming up. So it was just one of those things where, you know, you can never assume and you can never expect. And the best we can do is just listen and empathize with patients who are in that situation of managing such a large sum of money when otherwise they live paycheck to paycheck and have very difficult times managing that.
You know, and in all of this, we need to give a lot of grace, because frankly, I need a lot of grace every day. And so this is a very scary time for all of us to be able to do, you know, we're using technology to do this interview because we shouldn't be in person. And, you know, we shouldn't expect better from, how would we react in a situation like that? I don't know. But hopefully, you know, it's pleasing. It's good to hear that the patient trusted you enough to be able to speak to you about this and how bad he felt about this, because it threw off his blood sugars.
Yeah, and what I was expecting out of all this were patients coming to us concerned because they have diabetes, and all we hear about is how chronic conditions affect the prognosis or the long-term outcomes of people who are infected with COVID. So I was anticipating having discussions about how managing diabetes will lessen your risk of complications if you develop it. But no, it's more about the money and the loss of job and the loss of insurance and what people do to sustain themselves in this time. And again, it just hits home that if you have these preconceived notions and you expect to know what to talk about in a conversation, then you're never going to connect. And we just need to be active listeners when patients are talking to us, because they care about and have prioritized things completely dependent upon their life and their experiences. And we shouldn't try to put our experiences onto them.
And who are we to judge? I stress eat all the time.
Yeah, no, everybody has you know, things that they wish they could change and things that they know are not great for their health. And nobody likes to be told, hey, you shouldn't do that. We need to figure out ways to help people understand that we can do better than that. But it has to come from the patient. It can't come from us telling them, unless they flat out ask, what can I do or what should I be doing? That does happen, but we need to make sure we're taking a more patient-centered approach, figuring out what matters the most, and then we'll figure out how to go forward.
Wow, I could go all day long, and I'm not going to make you go all day long, but I want to ask you this question before we start to wrap up for the day. What gives you hope in this area of pharmacy that you haven't been in it that long, but you've seen a lot of changes at the time that you've been in it. So what gives you hope?
Yeah, I mean, that's a tough question to answer from my perspective, because there are so many avenues that I get hope from. You know, I get hope from patients who have gone through experiences that I could not even fathom, and yet still maintain the most positive outlook, who are the most dedicated and motivated individuals who make me a better person, even outside of my pharmacy career. The students I work with give me hope because their passion and their enthusiasm for continuing work like this, I can only imagine. I hope this is what the pharmacist mentor that I mentioned before felt like when I was in the pharmacy working for him. Just the, you know, admiration for the younger individuals who see this as a very valuable career path. And then honestly, hope from, you know, the healthcare system at large. We've made incredible advances in what pharmacists can do for patients in a very short amount of time. So if we think about it, really the evolution of clinical pharmacy and primary care pharmacy really got its mainstay somewhere in the early 2000s. So it actually hasn't been around that long for pharmacists to be embedded into a clinical practice to care for patients. And Wisconsin is one of the very few states that allows pharmacists really to practice at the top of their license. So Wisconsin has a statute that says any pharmacist can provide a patient care service delegated by a physician. So if a physician delegates that a pharmacist can do this, legally a pharmacist can do this. So it's the hope that states who don't have such an infrastructure or who are struggling with the idea of allowing pharmacists to do these things can turn to those states and those healthcare systems that have been doing it for years now to see what benefits it can provide. And I'm intentionally going to avoid the financial benefits because for me, it's more about the patient. And if we can make communities healthier through any healthcare professional that can do that, then that ultimately is going to make that healthcare system improve financially and kind of have waves that kind of ripple out from there. So when you ask where my hope comes from, it comes from so many different angles. And, you know, I hope it never stops coming from so many angles. I like the ability to work with so many different people, and whether those are learners, patients, colleagues, because I feel like, especially in difficult times like this in healthcare, we need to rely on one another so much for the strength to continue treating patients and to really just continue when times are very difficult. And patients who are experiencing all of these downturns as well can often be that source of hope as well.
Dr. Lamberton, I just have one final question. Will you come back again? And I'm hoping that you've talked about this, these success stories. Can you bring a patient back and we can talk together about this journey that you and that person has been on?
Yeah, I think that would be phenomenal. I have a lot of patients that are very entertaining based on my visits with them. But I would be more than happy to bring somebody back and we can share what this looks like. I think in application, I think sometimes it's hard to understand when we talk abstractly about what this looks like and how I approach a patient, but a patient perspective on what it's been like to be, you know, in this kind of discussion and to see it from the other side, I think would be an incredibly beneficial addition.
This has been such a joy to talk to you today about your journey as becoming the clinical pharmacist that you are, and I will say this, the advocate for the community and the patient that you are. Never stop being the teacher because you're never going to stop being the learner. I can tell that from you. So I want to thank you, and we will see you next time. Thank you, Dr. Lamberton.
Terrific. David, thank you so much. Pleasure to be here, and I very much look forward to our next conversation.
Oops, cancel. What an outstanding episode today. I'm so glad that we could have Dr. Lamberton speak into what does it mean to be a pharmacist and what does it mean to be a pharmacist that's community engaged. And he talked about getting to know the patient from their perspective and how their lives are complex and it's often seen like a puzzle. He spoke of this idea of not only to listen to give them the response from a medical perspective, but also to listen to understand. And he spoke of the idea of that better appreciation for the lives of the patients. He invited patients to share their story and to continue to never have all the answers, but to deepen what the patient's story means to him and how he might care for those patients. I hope you've enjoyed this recording of the Days of Life podcast. It gives me a lot to think about and how we interact with the community and how we learn from the community. I hope you'll join us next time when we have other individuals who can speak into health and wellness and how we can be better connected together. Until next time, I hope you have a blessed and healthy day and continue to be well and to learn. Goodbye.